What you are about to hear is not a podcast. This is a global conversation recorded live in real time with real people.
Journalists,
business leaders,
academics, politicians. I think the terms are deep state. Oh dear.
investors,
Experts, diplomats.
citizens.
Coming together from around the world to share their views and ask our guests the questions. If you would like to join this conversation or hear our incredible library of past conversations, please visit our website, pm101.club, and join the fastest growing conscious community on the free internet. Thanks for being here.
Enjoy the
Enjoy the show. Hey everyone, welcome back to Politics and Media 101, the place where we all hear live and direct from people in the news, in their own voices, in their own words, in long form, and where anyone who wants to can join to ask them a question, share their thoughts, or just listen. I'm Jeff Browning, and I'm grateful to you for being here. Today we're excited to release part of a conversation, interview, and audience Q&A we had with Dr. Stephen Morrison, Director of the Global Health Policy Center at CSIS, the Center for Strategic and International Studies. The COVID pandemic has impacted every one of us, and it's clear many are losing patience with masks, social distancing, and other measures put in place to address it. And while many places in the world lack access to sufficient healthcare infrastructure or vaccines, even in parts of the world where populations are lucky enough to have these resources, the pandemic has been accompanied by a separate infodemic. People are turning back the clock on hundreds of years of scientific advancement, denying the protection science affords us, and overall making the pandemic longer, deeper, and deadlier than it needs to be. Between the stress, the economic havoc, conflict, mental health, and other overall impacts of the pandemic, it's not surprising that we look for comfort. If someone comes along on the internet and says, "Don't trust the others, you know better, come with me for the real truth," it's like emotional comfort food. It feels self-empowering, which is especially appealing given that the pandemic has taken so much away from so many. This is why we were particularly excited to speak with Dr. Morrison. He's one of the world's most credible experts on the current status of the pandemic, what's known about the truth, what's not, how things are changing with variants, the specific challenges countries without resources are facing, and the specific challenges countries with resources are facing. COVID has brought on a sea of difficulty for many of us, and it's our hope that you'll find this update useful as well. After all, even conspiracy theorists would agree, arming ourselves with information is important. It was a great conversation with fascinating audience questions, and we hope you enjoy it as much as we did. As always, if you like or dislike what you hear, if you want to find out how to join us live almost every day of the week, maybe ask one of our upcoming guests a question, or hear past episodes, please visit our website, pm101.live or pm101.club. They both work and will get you to the same place where you can find all that and more. Without any further ado, let's roll the tape.
So, Dr. Morrison, I'd like to first thank you very much for being here with us today, and then ask you to set the table just a little bit about what we so far know about the Omicron variant in terms of transmissibility and how it compares to the Delta.
Great. Well, thank you so much, Justin. It's a real pleasure to be here today. A little quick scene setter on this. The Omicron variant first came to our attention in South Africa and Botswana in the latter part of November. Some early sense of this was coming up through various labs and others. It was declared by the World Health Organization a variant of concern November 26th, which was a very, very fast decision that was, I think, a signal of just how seriously people are taking all of this. One thing we need to emphasize is that this is not a variant that grew out of Delta. It is a new lineage. It is a new strain. It was known that this form was recognized early in 2020, but nothing was happening there, and we really hadn't heard much about it since mid 2020, and then suddenly it comes raging back, and it shows up with a remarkably high number of mutations in and around the spike protein, which is the most important part of the genome, which pierces the cell. There were 32 mutations, 26 of which were unique, had not been seen before. And then there were another 15 to 18 mutations outside of the spike protein, also in areas of the genome that are quite sensitive to issues around transmissibility and how much disease is caused and the like. So people sat up in their seats. They wondered, okay, how did this happen? And we can talk a little bit about that. But there are three main questions that people are rushing now to try and answer. One is what you raised. Is this more transmissible? Does this move more quickly? Is it more contagious? The second issue is, does it cause more severe disease or less severe disease? And the third issue is, does it evade protection? Does it evade immune protection, either protection acquired from an infection or protection acquired through having two vaccinations or full vaccination plus a booster shot? And so it's taken off in South Africa. It gained dominance in South Africa in just a matter of a few weeks, and there was the speed of transmission caught everybody. Caught everybody's attention. It was an almost vertical spike in the case count. Keep in mind, South Africa, not unlike Florida or Texas or Arizona, had a wave of infections earlier, and then the infections had dropped down to almost nothing. And you have a population that has some immunity from infection, fairly low vaccination levels, very little in the way of boosters, and you have high vaccine hesitancy and refusal. And so it was into that setting that Omicron was introduced, and it's just taken off, and the transmission is moving very, very fast throughout Southern Africa. Of course, now it's spread to 57 countries. It's in more than 24 states in the United States. As you referenced, we're seeing cases here in the United States. You have to be looking for this and doing genomic sequencing in order to see it very clearly. There is laboratory capacity and genomic testing capacity in South Africa, fortunately, and in Botswana. That's a result of the 20 years of investments in HIV and plus tuberculosis, but it's a reflection of how much capacity has come about over those 2 decades. We're now seeing it double every 2 or 3 days in the UK. UK has very, very extensive sequencing capacities. It's also moving very fast through Denmark, which has exceptional capacities. In the United States, we're doing sequencing with 5 to 10% of cases. We're doing about 10,000 a day. In this country, that's a significant improvement, but it's still far short of what we need. So we're playing catch up there. Now, your question, what do we know? There are studies that are being done in South Africa. There are studies that are being done in dishes, in laboratories. There's studies being done of clinical data in South Africa, in the UK, in Sweden, in the United States. Industry, Pfizer did a study that was released last week. We are not at the end of the road here. There's a lot we don't know, and we won't know for several more weeks. But just to quickly summarize what I think we do know on transmissibility, keep in mind the Wuhan virus, the ancestral virus, the beginning, the original virus. It was the level of transmissibility was about 3 to 3.5 people would be infected by an infected person in the course of that, if there were no protections. If you just put people in a room, that number was doubled with the Delta. And now what we're thinking is that it's increasing significantly by a factor of 2 to 3, but there's debate going on as to exactly how much of that, how much more contagious. Some of this is also having to tied to immune evasion. And what I mean by that is Omicron is clearly able to reinfect people at a very high pace. That's one of the things we've seen in South Africa. So a third of Americans have been infected. That brings some immune protection, but with Omicron, very little. We're also seeing immune evasion among those who are fully vaccinated, that is with 2 vaccines of the mRNA or 1 in the case of J&J. And we're seeing that from the early tests that the protections provided by those have dropped dramatically. We're also seeing that if you have booster shots, your protections are remaining pretty strong. So the speed of transmission, the transmissibility and contagiousness is tied to the fact that it is able to go out and attack populations that Delta cannot attack because Delta is running up against these immune protections. Omicron, which is a totally different lineage of the virus, is going out and hitting these populations that we thought were protected. As for the severity of disease, the verdict is not in. There's a lag in people getting infected and getting hospitalized or passing away because of this. So extreme illness, hospitalization, mortality, death, we won't have that data for a while. There's been some clues or suggestions that it may be milder. Some of that data, there are small data sets from South Africa and elsewhere. Some people have said, well, look, a couple of things are at play that may skew our appreciation of whether it is more dangerous or less dangerous. One is in South Africa, a overwhelming proportion of those who are getting infected with Omicron are very young. And so the age profile matters very significantly. Another factor that people are citing is that while Omicron may be able to pierce the immune protections that people have from either infection or from vaccines, those immune protections may still guard against severe illness and death. So it doesn't mean that the virus is less dangerous. It means it's in those populations that were previously infected or vaccinated. It may be able to make those people sick and infect them, but it may not carry them to severe illness or death. Many of the experts are emphasizing a very important point, which is if this Omicron is as fast and contagious as we know, and if it is able to evade immune protections, whether infection or vaccine, the sort of full vaccination, non-booster populations, it's going to spread really, really fast. And the population infected is going to get to be quite large. Those that have some immune protection maybe have less severe disease. But if you are unvaccinated and you have not been infected before, you're in harm's way. And some are suggesting that we could have 50, 60, 80 million people in America infected very rapidly by Omicron. Many are predicting that it will take root and become either dominant or coexist side by side with Delta as of the second half of January and into February. So it's moving exceptionally fast in Britain. I think the population profile in Europe is closer to that of the United States in terms of the percentage of people who are fully vaccinated, the percentage who are getting boosted. And so people are watching very, very carefully what is happening in Britain and in other and in parts of Europe where we're seeing it move with lightning speed. It's coming here. We are, I think, going to have to get our heads around what this means over the long term and begin to prepare ourselves. I'm worried because our population is very, very tired, very exhausted. Many people are frustrated and very angry with what's happened. We're very polarized. Many people feel like they're done with this pandemic and don't want to go back to restrictions on movement, restrictions on socializing, mask wearing, and the like. There's no magic answer to Omicron. It's back to basics, basically. It's get boosted as quickly as possible. If you're not vaccinated, get fully vaccinated and boosted as quickly as possible, and begin to reintroduce social distancing and testing and quarantine and isolation. And we're going to need to expand our genomic sequencing significantly. And we're going to have to be very careful in this next period. I'll stop there.
No, that was a fantastic table setting for us, Dr. Morrison. I have to thank you very much. So just to quickly recap, sounds like Omicron has been around for a while, but just recently it began to become the dominant strain in South Africa, and now it's spreading across the UK rather fast. As a result, we are concerned about it spreading here in the United States, with worst estimates looking like maybe 50 to 80 million people could eventually get this thing in relatively short order. So before we go into some of the known things, and you also hit on in that recap, which was awesome, transmissibility, morbidity, and also potential for breakthrough of the vaccines. And it sounds like, while data is preliminary, that it's relatively positive on the vaccines and boosters. If you have your booster relatively up to date, you're probably, hopefully, going to be okay, but we need more data on that. Morbidity, very, very early data. Hopefully, it's not as bad as maybe Delta or other variants. And then transmissibility, it seems to be have the potential to spread like wildfire. So I want to touch on that last thing that you just alluded to. Let's say we do have maybe not a worst case scenario, but let's say here in the United States, we do suffer a big outbreak, 50, 60, 70 million people get it. You've mentioned virus fatigue. We also have opposition to vaccines and masks, even social distancing in some cases. So with the exception of just getting everybody vaxxed and booster shotted up, what realistic tools in the toolkit does the U.S. government and specifically Biden have, considering the status of COVID-19 in this country, how it's very polarizing, and how half the country maybe doesn't take it seriously? Is a mask mandate on the table? Is social distancing on the table? And would lockdowns at the state and local level, and maybe a guidance from the federal level, be on the table, and would they even be helpful? So I know that was a lot, but I'd love for you to walk us through our domestic.
All right. Let me say a couple of things just before answering your question. On the origin of the Omicron, we don't know exactly how such a thing happened, where it went from a relatively inert and a non-threatening variant a year and a half ago to suddenly emerging with 50 mutations, of which 32 around the spike protein and 26 of those 32 unique. Keep in mind, when Delta arrived last spring and then took off in the United States in June, July, it had 8 to 10 mutations. Now, so something happened dramatic in transforming this lineage. There's one theory, which is a very interesting and intriguing theory as to how this happens, and that theory is as follows: that there's a certain proportion of people out there who are severely immune compromised. They could be organ transplant people. They could be cancer people or cancer survivors, or people living with cancer and with severe immunocompromised systems. But they also could be people, and there are many of these people in Southern Africa who are living with HIV, living with tuberculosis. They may be off of therapy. They may not be on therapy. They may not have been tested and put on therapy. In South Africa alone, you have a population of 60 million. You have 8 million people living with HIV. Of that population, I'd say probably 2.5, 3 million don't know their status, are not on therapy. And then you have another portion that may be lapsing on therapy. So the thought is that this vaccine, this virus gets into the bodies of these individuals, and those individuals are so compromised they're unable to clear the virus. So the virus stays inside these individuals for a very long period of time, and you have that then become the host for multiple replications and mutations over an extended period of time, and that's how you wind up with this very unusual situation of a new lineage with 50 mutations on it. And so that theory is a very credible and plausible theory, but it points us to understanding that there's a very strong linkage potentially between how we deal with HIV in our own country, but also in Eastern and Southern Africa, where most HIV cases are concentrated, and how we deal with COVID. It links those two epidemics very, very profoundly to one another, and that's new and different. Now, back to the United States. Keep in mind, we are right now in the midst of a major surge of Delta. Winter has set in. We're in a winter wave. Our case counts have been going up very rapidly. Hospitalizations are going up rapidly. We're at about 120,000 cases per day and about 1,200 deaths per day. That's driven by Delta. So we also are entering the flu season, and we're expecting to see flu come back, because last season we saw minimal flu, but that was when we had lockdowns and heavy mask mandates and the like. Now, so there is the possibility here that as we head into January, we have a Delta wave rising. We have flu season kicking in, and then we have Omicron introduced into the mix. It's possible that Omicron can outcompete Delta. It's also possible that Omicron can coexist, so that we're dealing with two very dangerous variants at the same time. What are the tools at our disposal right now? Our tools are the basics, right? Masking, social distancing, staying away from congregate settings, indoor congregate settings, increase and improve substantially ventilation. We can move to mandates in terms of mandating vaccination. Perhaps we move towards mandating boosters. There's a great resistance at the federal level by President Biden and his administration to move towards reimposition of lockdowns for the reasons that I think we've already discussed, which is Americans are deeply polarized, but also they're exhausted and they're fed up with these restrictions. And so a lot of the non-pharmaceutical restrictions instruments are kind of off the table at the moment. Maybe they get re-examined if we reach a point soon at which our hospital systems are overwhelmed. That becomes potentially a major trigger moment. And right now, in the 120,000 per day, the hottest zones of outbreak right now stretch from the Four Corner area of the Southwest, Utah, New Mexico, Arizona, Colorado, to the upper Midwest, Michigan, Minnesota, Illinois, up to upstate New York, Maine, Vermont. Those areas have high. Many of those areas have high vaccination levels in the Northeast and the like, and their hospital systems are very stressed right now, and they're near capacity. Many of them ICUs. The other thing I want to emphasize about our system is that our health providers, our workforce in our clinics and in our hospitals and other providers is exhausted and have been at this for 2 years. And many of them are trickling away. They're retiring. They're changing their work orientation and doing other things. If you go into a lot of our major hospitals, you find that a very high percentage of the nursing force are traveling nurses. That is, they're contract nurses who come in for an intense period of, say, 3 or 4 weeks. On contract, they may come in from anywhere around the country, but then they go and they take a break. They take a significant extended break. That's how much change has happened in this period. State and local authorities retain the capacity to introduce controls in terms of mandating masks. You had New York City and New York State begin to reintroduce mask mandates. Obviously, we have locked up in our court system right now the action by the Biden administration to begin to mandate businesses with over 100 employees either have full vaccination or move towards institute regular testing. That's being challenged in the courts, and we'll see what happens with that. That's still to be determined. Thank you.
So the U.S. responded to Omicron's emergence by banning travel from 8 southern African countries upon detection of the variant and it becoming more prevalent. In your view, could this be an effective policy for limiting the spread of this variant? Is it a well-reasoned approach, or is it more reactionary and punishing a country for detecting?
Okay, the decision to ban travel from South Africa and 7 other southern African countries. Let me take that, and then there were some other changes instituted on travel. That was motivated by the desire to move fast and buy a little bit of time in delaying the arrival or proliferation and dissemination of Omicron into the United States. I believe that many people are very, very skeptical that it will have much impact in slowing things down, perhaps a bit, but Omicron is moving really fast, and certainly what we've seen in the earlier phases with the original Wuhan virus and then Delta is that these travel bans are not very effective. Now, the Southern African states took great offense at this measure. They saw themselves, Botswana, South Africa, acted with enormous professionalism, speed, transparency, and accountability in sharing the genomic data on this and disclosing and alerting the world and making use of their extensive and impressive laboratory and scientific capacities and their genomic sequencing capacities. So, in retrospect, if we were going to put temporary controls over travel upon those 8 countries, we should have paired it with a much more deliberate and significant expansion of support to South Africa and Southern African states in all the different ways that they're asking for support in their national efforts in dealing with this acute phase of COVID. The administration was heavily criticized. It did respond a few days later with some expanded assistance, but I think the harm was done. And there's enormous anger within Southern Africa around these measures. The other measure, there's a couple of other measures that were taken prior to Omicron. The policy of the United States was that if you're coming from anywhere outside the United States, you needed to provide a test within 72 hours of return, showing that you're free of the virus. That was changed to 24 hours. That has been disruptive, obviously, to the travel industry. The travel industry was very disappointed in that because they have had a slow recovery. The United States had just reopened to a lot of international travel in early November. And so there was hope that we'd be heading into the holiday season. We'd see more international travel. I think that adjusting to the 24-hour requirement for most places, I think that can be handled. That will be done. The other thing, another thing that the United States has done in this period was enhance surveillance at 4 major airports that are ports of entry to the United States. That includes JFK, Newark, Atlanta, and San Francisco. That was a measure very similar to the measures taken during the Ebola outbreak in 2014 and 15 in West Africa, where there were calls to shut our borders, and the response was to do screening, enhanced screening at those 4, at I think 5 gateway airports, and that was highly effective. That was very, very effective, so I think that's promising. I think that the administration is proceeding in a kind of incremental way. In other words, now that we see that Omicron has spread to 57 countries, they haven't expanded the ban to 57 countries. There's a moment of reckoning here in trying to figure out how to proceed moving ahead. Once you impose these bans, it becomes a more difficult and arduous process of lifting them. Obviously, Southern Africa doesn't account for a huge volume of traffic with the United States, but many of the early cases detected in the United States did originate in travelers, people traveling back and forth between Southern Africa and the United States. But now we're beginning to see more cases that are community transmission. That is, cases that are coming from people in the United States, not clear where they picked up the virus, but they're passing it on to one another. That's what we mean by community transmission. So there was certainly a political motivation in jumping forward in the way that the United States did. Many other countries did the same, and so the impact was felt, particularly cruelly, I think, in Southern Africa. Southern Africa is entering the peak of its own summer season and the high holidays and travel and vacationing in Southern Africa, and so this is going to hurt the industry, hurt the tourist and travel industry significantly. Of course, as Omicron spreads, many travelers are going to make decisions quite independent of travel bans to stay home, I believe, in this period. But we'll see.
Thank you for that. I guess just one more follow on there. Will the travel bans disincentivize countries from making aware that there are new variants out there, in so much that they don't want to receive the stiff backlash that South Africa did, and they might take their chances with the variant spreading and then people not being able to find out the origin of it? Or is that not realistic?
No, I think that you're on to one of the most critical issues about readiness and preparedness for dangerous pathogenic outbreaks, which is wherever they appear, wherever these dangerous pathogens appear, the leadership of that country is going to be very, very cautious and very reluctant to sound the alarm when that leader is thinking this is going to lead to a very strong reaction in terms of disruption of trade, of travel, of investment, of marketplaces, and so you saw what happened on Wall Street, and in global markets right after the first declarations, after the November 26th WHO declaration of this as a variant of concern. There was a very strong reaction, an an excessive disruption in the global markets, and overreaction, really. And so, yes, there are built-in disincentives for countries to live up to their obligations under the international health regulations and be fast and transparent in disclosing these dangerous new pathogens. Sometimes you have no idea, as we've seen with Omicron, exactly what you're dealing with, and you are opening the way for lots of other investigators to get involved, and that can be very uncomfortable. I think the South African officials and the South African scientists, and the same is true of those in Botswana and some of the other Southern African countries, have been remarkably honorable and professional in this period. And they deserve praise and they deserve credit for what they've done that has greatly benefited us in this period. The scientific community moved with remarkable speed in the last 3 weeks. Let's give that's a global phenomenon. I mean, the level of field trials and laboratory tests that are underway right now, the levels of analysis of the genomic data that's coming into these shared databases that are globally accessible. This is a new world, and it's an impressive one, and it's one that we're very reliant on in trying to figure out what the answers are going to be. And we need to not do anything that slows or disrupts that level of professionalism and transparency.
So I just have one more question for you, Dr. Morrison, and it's about global vaccine supply. And then we're going to kick it over to the audience, and we'll go Farai first, and then we'll go to Peter Chow next. But in developing countries where vaccines have become available, what are some of the issues in preventing shots from getting into arms, specifically, Dr. Morrison? We have seen reports about vaccinations being donated from European countries to developing nations too close to expiration date, only 2 to 4 weeks before they expire, and then certain countries having to throw them out. But I'm wondering also, in addition to that obstacle, are there also infrastructure, cold storage issues in developing nations that are preventing deployment, even if, for example, the US and world were to give 1 billion vaccination doses or 2 billion vaccination doses to different developing countries? Would they be able to immediately put those shots into arms, or do they lack the infrastructure and storage to actually get that?
Thank you very much, Justin. Just a few key facts to keep in mind when we're talking about the vaccine crisis or the vaccine gap. Low-income countries, those that are the poorest, that have the weakest infrastructure, most fragile economies, low-income countries are running at vaccination levels of 7% or less fully vaccinated. Most of the high-income, wealthiest, most powerful countries in the world are running at 60 to 75% fully vaccinated. And then you have in the middle-income countries, lower middle-income countries, many of which are making significant progress. But the fear here is that the poorest countries are going to be left behind. It's going to be a very slow process of getting anywhere near the levels required. Omicron is showing us that 80% is not going to be good enough. We're going to have to move higher and higher. We're going to have to move to boosters. And yet we're not even out. Much of the world is not even out of the gate with getting a first vaccine, much less a second vaccine or a booster. Now, supply constraints are easing. Production is expanding. This year, there'll be about 7.9. We're at about 7.9 billion doses that have been administered. Production this year will top out over 12 billion. And that includes the Chinese vaccines. Production is expected to double in the next year. So there's a lot of investment in manufacturing capacity. Not enough yet in low-income countries near the source of what's needed, but there's some efforts underway in South Africa, Rwanda, Senegal, elsewhere. The production is running at over 1 billion per month. So supply is easing. That doesn't mean that it's still not difficult getting the right volume through the COVAX Solidarity Facility or through direct arrangements. And then once it lands in many countries, the two main concerns become the delivery capacity. Does this country have a system in place to take delivery, avoid diversion, make sure that it's managed, it's stored and handled, doesn't spoil, doesn't reach expiration date, gets moved through the provider system to that person who needs a shot in the arm, that get through that last mile. It's a complicated set of things that have to happen in terms of health provider status, regulatory environment, delivery, management, handling, transportation, and logistics. There's a lot of different estimates of what the true cost is for delivering a vaccine, but it's expensive and it takes time and effort. So there's a big race underway right now to understand how well prepared are countries, what are the main gaps that they face, how can external support be best focused in this period, and what's it going to cost. USAID just announced last week a $400 million initiative in this regard. That's a good start, but it's far less than what actually is required. The Global Fund to fight HIV, TB, and malaria has been moving over $4 billion of resources towards non-vaccine support, PPE, testing, ventilation, oxygen. Those are all critical component parts of the acute response, but also critical in strengthening health systems so that they can move the vaccines. The other big concern is hesitancy and refusal to take vaccines that's fueled by misinformation, disinformation, conspiracy theories, pervasive, pernicious, high impact, and governments are really, I think, just beginning to come to terms with how do we cope with this problem. I mean, we face a serious problem here in the United States. Roughly 20% of adults in one form or another hesitant or refusal, and we've been very slow to come to terms with that. And it's a huge vulnerability over the long term, and it's a complicated and difficult thing to address. And so those two things, I would say, are terribly important. We are going to see vaccines hit expiration dates. There was a report out last week of 1 million doses expiring in Nigeria. We're seeing some countries turn doses away because they don't feel that they have the capacity to administer that volume in the time required. They would prefer smaller volumes that are more manageable given the limits of their capacities. So this is all by way of saying, for the international community to support low income and lower middle income countries that are struggling to vaccinate and bring all of the other inputs required for this in this acute phase, it's not just vaccines. The vaccine supply remains a very important issue. COVAX has had a very difficult year. We can talk a bit about that. It had hoped to move originally 2.3 billion doses to 92 low and middle income countries this year. It's ending the year at about 800 to 900 million, far below those original targets. It got hit badly when India imposed a trade export ban on vaccines when the outbreak hit them badly in the spring, in March and April. They're beginning to lift those export bans, but it's done some real harm, and COVAX has had a tough year. I think they will begin to do better in the new year. Others have come forward. Other countries are cutting their own bilateral deals with manufacturers, but also regional bodies have come forward and playing a very important role. The Africa CDC and the Africa Union together have formed a vaccine initiative, and they are they're placing big orders. And we're seeing the EU step forward also as a regional body, making commitments 500 million doses towards COVAX. The United States has committed 1 billion doses of Pfizer. That gets to one of your questions around handling. Now, you need deep cold storage capacity for Pfizer. That means that you're most likely going to wind up having that 1 billion doses that will be delivered between now and next September will probably be deployed into urban environments where you have the urban and peri-urban environments where you have you can create that kind of storage capacity. There's been a big race to try and expand those cold storage requirements so that the Pfizer can be introduced. They're beginning to roll that out at about 50 million a month right now, and that will expand as we head into 2022.
Thank you very much for that answer, Dr. Morrison. We will go now to the audience, and we will go to Farai first, Peter, and then Piotr. Farai, over to you, good friend.
Thank you, Justin. And thank you, Mr. Morrison, for great analysis, I think. My question is really around two aspects of this current Southern African outcry. But I think most likely we can call it an African outcry about the actions that have been taken with regards to the travel ban. So, firstly, one of I think the head of state of Botswana, when he was on CNN, he talked about how it continues this paternalism approach as far as when it comes to dealing with Africa, especially if one considers the fact that the approach in itself sort of banned a swath of African countries, reinforcing the very stereotype that one would hope Western states would be moving away from, so that it's more collaborative. And then, of course, add to that the fact that African states have been crying about the fact that there's a vaccine apartheid, if you will, purely lack of access. So my question to you is: do you think, in terms of the corridors of power, is there a slight shift in thought and approach in light of these concerns that are being raised, and equally the actions that Nigeria took today of actually banning itself, banning United States entry and the United Kingdom and so forth? Do you think these kind of actions that are somewhat where African countries are saying that it sort of harkens back to a colonial relationship, do you think that has held any sway in the corridors of power in terms of the opinion and the actions that will be taken moving forward?
Thank you, Parai. That's a great set of observations and questions. I would respond in a couple of different ways. There was the G7 summit in June, at which many leaders from the Global South, several leaders from Global South were invited to come and speak. There was the September 22nd summit that President Biden called on the margins of the UN General Assembly. There was a ministerial meeting of foreign affairs ministers that Secretary Blinken called in early November 10th. There's the G20 summit just happened. At all of those settings, there were very strong and sharply worded statements coming from various parties. President Ramaphosa from South Africa was very vocal. Heads of state from India, from Vietnam, from Indonesia, Thailand, and there were some common themes there. One theme was we're not looking for charity. That's an old paternalistic model. We're looking for accountability and transparency in the global marketplace for vaccines, and we're looking for serious commitment by partner countries in the North to create new capacities. And particularly, they're very disturbed by the inequities in the global marketplace and the fact that there was such extensive hoarding and nationalism in the most powerful countries in the first phase of this pandemic that left them high and dry and living in uncertainty for such a long period of time while their situation was becoming more and more desperate. So I think that opinion has registered. I think that there is a recognition, certainly within this administration and other Western powers, that there's a lot more work to be done in listening and understanding the perspective of the global South. There's a lot more diplomatic investment needed in outreach. There's a lot more needed in supporting regional bodies, whether we're talking about Africa CDC and the African Union, whether we're talking about ASEAN, whether we're talking about PAHO in Latin America, that we need to intensify that engagement and really try to accelerate these regional capacities to produce mRNA vaccines and other very promising vaccines, and try to figure out a way to do that so that those production capacities are sustainable. So there has been a shift. One other thing I want to mention is this sense of outcry in Southern Africa, and this sense of paternalism and this disappointment comes against a backdrop of the U.S. commitment through its PEPFAR program, the President's Emergency Plan for AIDS Relief, which has invested $90 billion in building capacity and building partnerships in Southern and Eastern Africa since launched in 2003, 2004, plus the Global Fund, which fights HIV, TB, and malaria, which the United States accounts for a third of its resources. These institutions have been partnering with Botswana, with South Africa, with Eswatini for 20 years now. And those are very mature partnerships, and they've had profound impacts. And they've raised the estimation in the United States dramatically. And so we have a foundation of goodwill, and we have a foundation of achievement and partnerships. We were pretty clumsy, and we forgot about that in the way we reacted to the Omicron. And but I also think that it's possible to recover if we are humble and deft and recognize the clumsiness of the response in this last phase. And if we are coming forward in the new year with a more systematic strategy of engagement, partnership, and investment in the most vulnerable countries.
Thank you very much for that question and answer there. We will go to Peter Chow, who is a biological PhD student at Stanford, and then we will go to Piotr. Peter?
Thanks so much for speaking with us, Dr. Morrison. So my question is kind of general, but then I hope you could take it into like a comparative international angle. It's just, how has Omicron changed, how people perceive or the perspective on the general outlook of the pandemic? Like, in that, is it now like our recovery is going to be longer? And generally, the comparative political angle, I was kind of curious on this, is this something that, Omicron coming, this kind of a totally different variant, something that was just always a possibility, and that, certain countries are actually less affected actually by this variant, and the timeline of their COVID recovery is less changed. So kind of, what countries in this world, if any, has this new variant not really changed the course of the pandemic in their country? And is there anything kind of we can learn about politically how to deal with this, so we can really, think about our own actions rather than, the course of a virus and, mutations that are probably beyond our.
That's a great question, Peter. First of all, Omicron is this new lineage, it's still very early days. It's still very fresh. There's still much we do not know. I think we need to be humble, and it is going to have profound consequences. Exactly what those are, we can begin to speculate. It's still early days, but I would say a few things. One is, of course, Omicron confirmed what many people have been saying, which is if you do not attend to large populations with uncontrolled transmission and uncontrolled replication, particularly when you have large populations that have immune compromised people like we have in Southern Africa, you're going to see a continued generation of dangerous new variants that threaten all of the progress made around the world because this stuff moves so fast. And Delta, we saw, came out of, originated in India. It took 3 to 4 months to consolidate its dominance in the United States. That's a very fast pace. Omicron, it looks like it will establish itself in Britain in a matter of 2 to 4 weeks as a dominant factor. And there's no reason why we will be an exception to I think what happens in Britain will be a pretty good precursor, pretty good predictor of what lies ahead just a short time after that. So we've had to face up to this startling reality that we remain very, very vulnerable. And what we're seeing is we thought 2 doses a short while ago. We thought 2 doses was going to be a ticket to freedom and security from the disease. Now we're seeing something that's suggesting no, that's not the case. We have a lineage out there that can pierce that. And now we have to move to boosters, and yet we have an enormous population that hasn't even gotten its first dose. So we have to square those realities. We don't yet have a plan or a coordinated plan of action globally for addressing all of that. We are clearly all forecasting for the future, is looking at boosters and looking at recurrent vaccinations. And people are starting to think about what do we do when we have multiple dangerous variants? Are we moving towards annualized vaccines that will be multivalent? That's something that's possible on the horizon. But I think the timeline, we're looking at a long war. We're looking at 4 to 5 years of dealing with this, and it's a difficult thing to get your mind around because as we started this conversation, people are exhausted, and so how do you get people to reset their understanding and reset their determination and not be despondent in this period?
Yeah, it's not an easy thing. So we will go to Piotr and then Tina for our last question of the evening before kicking it back over to Dr. Morrison for his last thoughts. Piotr, over to you.
Thanks, Justin, and thank you very much for joining us, Doctor. It's a very interesting discussion, and much appreciated your time. I'm very interested in the geopolitics of this, and the great power politics, particularly, as that's what I focus on in my work. And we've seen a lot of the great powers or the larger powers sort of finding ways to collaborate. Russia and China created a one-team mindset, I think, a year or so ago to help with developing sort of a strategical production of vaccines. And obviously the West has been sort of inconsistent in the way that they're going about it. And I think the one thing that has become evident from the pandemic is that realpolitik continues to be the prevailing way that international relations plays out. But I'm very curious to hear from you, sort of retrospectively, what lessons do you think that can come from this in terms of how we can try and foster more multilateralism in response? because COVAX has been a very inconsistently utilised and supported initiative. But also going forward, what do you think that this pandemic is going to have generally on the status of international relations and geopolitics between sort of Russia, China, the US, and the EU as such? If that's not too big a broader question, but
I would say that the first 2 years of this pandemic, we've seen the dominance of nationalism. We've seen countries turn inward in protecting their own sovereign stakes. The most powerful and the most wealthy have been able to dominate that process. We've also seen the dominance of the private sector marketplace. In other words, the firms that came up with the best product have had a pretty significant ability to chase the high profit markets and neglect the least profit markets. That's beginning to change, but that's been highly problematic. And so we've seen a highly fragmented, chaotic, and largely ineffectual mobilization internationally. We've also seen the deepening of the very toxic confrontation between the US and China. And of course, now that's sort of cemented into a broader opposition between the West and China over the COVID origin stalemate. And that's been very unhealthy, that we have largely a breakdown of collaboration and coordination between the United States and China. And we need to focus on trying to repair that and figure out a way forward. You cannot have coordination and improved governance around the response to this global pandemic with the world bifurcated into a kind of Cold War division between the US and China, or the West and China. There has been a lot of analytic work done in the 2 years. The WHO, the World Health Assembly commissioned an independent panel that produced results, quite impressive piece of analytic work. The G20 constituted a high-level independent panel that came out the end of last year with a very, very good analytic work. So I would say that the diagnosis of the problem and the diagnosis of what needs to happen, both in the short term and the long term, in terms of coordinated international action and investment, is better understood today. But what's been missing is the political will and mobilization to sort of carry this forward. And there has been a return in some respects to high-level diplomacy at the G7, the G20, not much at the UN Security Council. We've seen the US, President Biden, step forward, call a summit in September, commit to do a second summit in the first quarter of next year. I think that's promising. It needs to be translated into much more concrete action and deliverables, and I'm hopeful. So it's been a very disappointing and tough set of lessons in this first 2 years, and we've got to hope that that we'll see some change in outlook and change in behavior. Omicron may turn out to be something that is a moment of reckoning or awakening. All of these health security strategies and engagements tend to go through a cycle of crisis followed by complacency and neglect. Well, Omicron is going to keep us in crisis. It's going to keep us focused. Let's hope it doesn't drive us back into our nationalistic corners. Let's hope it changes the consciousness of the fact that we have failed to come up with very good, durable solutions in this first 2 years. And we're paying a big price now, all of us, and we need a better form of high politics and engagement looking ahead.
To our last question, we will go to Tina, and then we will kick it over to the good doctor to give us his last thoughts. Tina.
Thank you, Justin. My name is Tina, and I'm just a Finnish citizen. I'm a European citizen. So my question is, Mr. Stefan Morrison, how do you see Omicron virus? Does it affect differently in cold environment in wintertime versus a tropical or Mediterranean environment, such as Italy or Southern Europe or in Africa? As you know, we have a winter time here in Scandinavia. Most of the parts, cities, they have a lot of snow and less light. And also we can have nearly 25 degrees at the moment in different parts. So I'm just wondering how Omicron virus will affect in our part of the world. And the second little question is, how do you see strategy for Omicron virus? We have a hybrid strategy in Finland. Sweden, they didn't close any cities, and they don't have to use, in Sweden you don't have to use even mask. So the strategy is very different, but they have 15,000 dead in COVID virus, and we have less than 2,000. And we will still have a hybrid strategy. What is your opinion about our strategy? Thank you. I'm done speaking.
Thank you very much, Tina. It's early days, and in terms of how the Omicron virus functions in cold environments versus warmer environments, I think that's all still to be seen. Obviously, Delta and earlier waves of SARS-CoV-2 peaked. The highest waves were in wintertime. I mean, the Wuhan virus, when it came to the United States and peaked last January, there was 1 week at which we had, over a 7-day period, an average daily infection rate of over 250,000 cases. We had one day that was, I think, 330,000 cases. The daily death count superseded 4,000 a day. On one day, it was averaging well over 3,000. These were astronomical numbers. So the virus thrives in cold weather. Populations move indoors, and so I think we need to be very conscious of that as we think about this. Now, your question around Scandinavian countries, you're quite right that the performance and the strategies across Scandinavia have been quite different. Finland's done quite well. Denmark has done exceptionally well. Norway's done well. Sweden's been controversial because of its leaned in the direction of an anti-masking strategy. It's at times appeared to be looking towards more of a herd immunity type of approach. But many of those high mortality numbers that you cited were gross negligence in the management of nursing homes, which fell under a different authority than the public health authority. And there's quite a consciousness within Sweden around that set of mistakes, and there's efforts being taken to make sure that doesn't happen. The larger problem that I think Sweden pointed us towards, which we have here in the United States and elsewhere, is somewhere but well over a third of the 800,000 people, almost 800,000 people who have died in the United States were in nursing homes. And we have to ask ourselves whether Omicron, if it comes in and accelerates, whether we're going to see a repeat of that pattern, and are we going to be doing enough to enhance the protections of people that are very, very vulnerable? Are these populations getting boosted at an aggressive pace enough? Are they fully vaccinated? Are staff getting fully vaccinated and boosted in this period. If we want to avoid that horrible outcome that we saw in many different places. Just one last remark. I mean, I've been speaking with the Danish about their program. You know, they have an exceptional surveillance, test and track. They have exceptional genomic sequencing capacities. They've really done very, very well at controlling the virus, but they're seeing record levels with the advent of Omicron. And they sent their children home from school. They closed school early. They have begun to curb the hours around restaurants and bars. They're experimenting short of shutting things down. And I think that is probably what we're likely to see in many different places, is not succumbing to the kind of hammer blow of full-scale lockdowns, but trying to have a more targeted approach in certain areas where we know the risk of transmission is high, and attempt to work that through. Countries that have a strong consensus, like I think it's fair to say that Finland is a pretty united country. And the same is true, Sweden, Norway, Denmark. There's a strong national consensus. There's strong compliance with public authorities and the like. That's enormously important in terms of trust and confidence, and an ability to win cooperation from a public that's scared and exhausted around these new kinds of measures. Where it's more dangerous, I think, is in deeply polarized and divided societies, and where we've already seen a propensity to violence around new mandates and new controls and pressures for vaccinations, and mandates for vaccinations, mandates for masking and the like. We've seen this across Europe in many different places, in France, in the Netherlands, and elsewhere. And frankly, I'm fearful that in those societies where there is not a strong consensus, but rather there's deep polarization, where the anti-vaccine movement is very strong and has allied with right-wing political movements, it's quite possible that we will see more escalating clashes. We've seen that in Austria, seen that in Germany. We could see that here in the United States. Thank you.
Well, thank you very much for your questions, Tina and everybody else. Dr. Morrison, thank you so much for your time walking us through something that a lot of the people around the world are fearful of. You've brought a new, sober, nuanced approach to this, and we greatly appreciate it. I just want to leave you the opportunity to give any last statements that you might have.
Well, first of all, Justin, thank you so much for this opportunity, and I want to thank everyone among the 1,000 people who are on board at this moment for taking the time to join. It's been a real pleasure, and I looked forward to today. And if in the future we can revisit these issues, I'm happy to do that. I think this is a wonderful forum. I like the format. I like the flow. I like the questions are excellent. This is a difficult and huge moment that we're entering right now. We shouldn't rush to judgment because there's much we don't know. But we've got to be paying close attention and thinking about it. And we're going to have to, I believe, make some adjustments in our behavior and our expectations looking forward. And the first half of next year is going to be difficult. We're going to be rocked. It's going to be tumultuous. It's going to be challenging. And we should begin to get our minds around that, but we can't give up hope. We will, the tools that we have, the scientific tools that we have, remain extremely important. We still have remarkable scientific capacities and great private sector partners in this period, and but we're going to have to change our game plan, I believe, in this next period and recalibrate. Thank you.
That's all we have for you today. Huge thanks to Dr. Morrison for coming out, to our audience for their questions, and to you for being here. If you like or dislike what you hear, if you want to find out how to join us live almost every day of the week, maybe ask one of our upcoming guests a question, or hear past episodes, please visit our website, pm101.club or pm101.live. They both work and will get you to the same place where you can find all that and more. This has been Politics and Media 101, produced in partnership with Clubhouse. I'm Jeff Browning. On behalf of Justin Higgins, our co-founder, and our team, thank you very much for being here. We hope to see you and hear from you soon.